I'm going to talk about the effects of childhood maltreatment and personality difficulties for ECT, for depression today. And, better figure out how this works. There you go. That's my only disclosure. One of the problems we have with treatment, I heard a bit about this already, really, from Andy's talk, is like, what works best for each individual under any given circumstances. And as I'm sure you know, ECT is, even after nearly 90 years, the single most powerful antidepressant treatment. But our knowledge of what are the clinical predictors of response or remission are actually not that large, and the effects aren't huge. Meta-analyses on the topic have shown basically the following, that a shorter episode duration, so more an acute episode rather than chronic depression, is favorable, with a standardized mean difference or effect size of about 0.37, which isn't that big. Medication resistance tends to reduce responsiveness to treatment with ECT. Psychotic features are good for remission with an odds ratio of nearly 1.5. Older adults do better than younger adults with ECT. And greater baseline depression severity also has a small effect, standardized mean difference about 0.2. And that's kind of about it up until recently. This meta-analysis from Ferreira, Petrides, and colleagues came out last year, looking at trying to pull together the rather disparate literature that's out there about personality disorders and personality difficulties or abnormal traits and response to ECT. And they meta-analyzed about 20 observational studies with nearly 11,000 patients with either a comorbid personality disorder or traits. Mostly traits, and most of these studies are kind of based on screening instrument data rather than a clear diagnosis. But nonetheless, within that, you can see there's a lower remission rate, the odds ratio 0.4, lower response rates, higher relapse rates, and interestingly, more frequent post-ECT memory impairment, odds ratio 1.4 in this population, compared to people who do not have personality disorder or problems with personality traits. So we were interested in this area in our research, and so I'm going to talk about two brand new studies that aren't yet published. One is to do with childhood maltreatment, and second one is to do with personality difficulties. So I'll kind of skim through these. So you're probably aware that, unfortunately, adverse childhood experiences are very common. In the depression populations, maybe 25% plus people will endorse these. We're talking about emotional abuse or dysfunctional home environment, particularly physical abuse and neglect and sexual abuse. These are probably the major drivers of these problems. We know that such individuals with this personal history have an increased likelihood to develop a wide range of mental health problems in adulthood. And even when you adjust for familial risk factors, because some of this is genetically driven, the association is still there, somewhat attenuated, but still a significant one. And not all forms of adverse childhood experience have equal effects. So certainly childhood sexual abuse has synergistic effects with other factors, is a big driver. In adults who do have childhood adversity, there are several clinical features linked to a poor prognosis. So the greater baseline depression severity, earlier age of onset, and persistent and chronic depression. By this I mean a depressive episode lasting, say, more than 2 years, or depressive symptoms persisting for more than 2 years that may not necessarily meet the level of severity for a depressive episode, and increased psychiatric comorbidity, so other problems as well, and suicide attempts to some extent. Also associated with and we know that presence of child maltreatment is associated with less favorable response to treatments with pharmacotherapy and psychotherapies, and increased risk of recurrent and persistent depression, although not quite a consistent finding, but seems to be intuitively sensible. We published some data from a pilot trial last year where we looked at about 44 people who had depression, who had ECT, who had retrospectively reported a history of trauma when we did a childhood trauma questionnaire with them, a sort of structured questionnaire. And we found that they were substantially less likely to respond to a course of ECT than those without such trauma, by a factor of nearly 50% in this small study. So what we want to do here was really expand on this and investigate the association between exposure to sexual and/or physical childhood maltreatment and response to ECT. So from now on, I'm just talking about childhood maltreatment, and by this I mean physical or sexual abuse or neglect, physical neglect. And then to try and identify possible mediators of this relationship between childhood maltreatment and ECT outcome. And in particular, looking at persistent or chronic depression and psychiatric comorbidities derived from the literature. So our hypothesis was that patients with a history of childhood maltreatment would benefit less from ECT, and that the deleterious effect of childhood maltreatment on ECT outcomes would be mediated by some of these clinical features. So to do this, we did a large retrospective cohort study at our centre in Dublin, St Patrick's University Hospital. This is an independent sector psychiatry facility, provides about 10% of mental health services in Ireland, but we actually do about 50% of all the ECT in the country, so we're kind of a national centre for that. And we also get referrals from the public health system as well. So to include in the study, we identified everybody who had ECT from about 2016 up until, actually it's March 2024 in this data set. And if they had more than one ECT course, just the first course was included in the analysis. So you had to be over 18 and have an acute course of ECT. And the diagnosis was a clinical diagnosis, so this is a retrospective study, case note study really, using the mostly electronic mental health care records. If you were having maintenance ECT, you're excluded. It's really just depression. We focused on unipolar or bipolar, and any other psychiatric episode you were excluded. But most patients in our centre have ECT for a depressive episode. ECT, I won't say too much, most people get unilateral brief pulse ECT, 1 millisecond pulse width. The odd person might get bilateral or ultra brief pulse. And we use established seizure threshold the first session, then treated 6 times threshold thereafter. But everybody got treatment as usual as well during their stay in hospital. And these were all inpatients, I should point out. So in terms of exposures, so we have a retrospective self-report, which is captured on admission to hospital. So as part of the admission process, everybody's asked about any history of childhood trauma or abuse, and that's documented, and then there's a free text description of that as well, which we then kind of coded. And we extract information from these. Anna and myself coded this, and with a good inter-rater agreement for this between the two of us. And now we did not look at things like emotional abuse and neglect because these weren't systematically documented really. In terms of outcomes, we are using the Clinical Global Impression Improvement Score. So a response of 1 is very much improved, 2 is much improved. So either 1 or 2 is responder criteria. Remission criterion is a score of 1, very much improved. Now I would point out, I think this is a much more stringent remission criteria than, say, using a cutoff on the Madras or Hamilton. So the numbers for remission are a bit lower than you might expect. But the response rates are pretty much what you'd expect. Now, we actually got these all rated independently by senior resident, and I actually double-checked 10% and a good level of agreement between us for that. So in terms of the mediators for this that we had hypothesized, comorbid psychiatric disorder, so any psychiatric diagnosis other than depression, and that including personality disorder and substance use disorders. We couldn't really separate these out because the sample size wasn't big enough, so we just merged any other comorbid psychiatric disorder together. And persistent depression, as I mentioned, was depressive symptoms lasting more than 2 years, whether it's the index episode or more low-grade symptoms. And then covariates that we adjusted for were age, self-identified gender, self-reported first-degree family history of any psychiatric disorder, and then these confounders, these are used as potential confounders in the multivariate models. We without going into too much detail, the usual stuff was baseline characteristics. We did logistic regression models for estimating the association between childhood maltreatment and then non-response or non-remission. So the data I'm going to present now are in terms of non-response or non-remission, the proportion who do not get better or do not remit. And then separate logistic regressions for each subtype of exposure, whether it's sexual abuse or the physical abuse or neglect, and ECT outcomes. And then logistic regression to look at the association between childhood maltreatment and these mediator variables, and then the relationship between the putative mediators and actual ECT outcomes. And these are just expressed as odds ratios, just bear that in mind. And then we also did, interestingly, a mediation analysis for those who enjoy this sort of thing. This excellent reference came out in the Journal of Politics, the only politics journal mentioned here at this meeting, I'm sure, where these guys from Harvard developed a new package called PATHS in R, which allows analysis actually of more than 2 mediators. Prior to that, 2 was the maximum you could do, and people would just look at them one by one. But of course, these mediators all interact with each other. I have to bear that in mind. So I'll say a bit more about that in a moment. And then we looked at the total and not total effects as well, with bootstrapping for 5,000 iterations in that analysis. So this is the study flow. So during this time period of about just over 6 years, we had about 800 people having an acute course of ECT. Nearly 250 of these had a repeat course from that time period, not unusually. Of this 550 or so left over, we excluded 51 because they had ECT for a non-major depressive episode. About 500 or so were eligible, and we excluded 4 because of missing data on the exposure of interest. So it was pretty good. 501 people were included in the analysis, so a pretty complete data set. This is an impossible figure to read, but I've summarized it here. So the CM group, the child maltreatment group, accounted for about 16.5%, 17% of the total group. A little bit lower than you might expect. Again, this is what's recorded on admission to hospital, so people divulge information later on, but we did not, we used electronic health records to just get that information on admission. But perhaps not surprising and consistent with the literature out there, the childhood maltreatment group were a bit younger, had an earlier age of onset, more of this kind of longer standing chronic kind of dysthymia picture, more previous admissions to hospital, more psychiatric comorbidity, and more family history. So breeding true, essentially. There are no difference for gender, education, legal status. By that I mean whether you're admitted to hospital voluntarily and involuntarily. The involuntary admission rate was about 10%. The duration of the index episode or the baseline severity, the presence of psychosis or catatonia. And there was no difference in the way people got ECT between the 2 groups. So this is logistic regression looking at the association between childhood maltreatment and non-response. This is the crude odd ratios here, and this is the adjusted odd ratios here. So just to show, so the reference is no childhood maltreatment in these lines here. And this is looking at the different types. So any physical or sexual abuse, there was a significant effect on the crude odds ratio, but we adjusted for these factors, age, gender, family history. There was no change, no difference. And again, we looked at childhood physical abuse by itself. The adjusted odds ratio was not significant. And we looked at childhood sexual abuse, again, it was not significant. However, and I should just say, this is the non-response rates. So in the no childhood maltreatment group, 21% of people did not respond, so 80% of people responded. And the other group, though, 30% did not respond to ECT. When you look at remission, which is a much more stringent criterion, the non-remission rates in the childhood maltreatment group was nearly 90%, so only 10% would have met remission criteria. Now that's with a score of 1 and CGI improvement, which is difficult to achieve actually. Whereas it's about no remission status of 70% in the no CM group. And again, when you look at the adjusted odds ratios here, these hold. If you have any physical or sexual maltreatment, the odds ratios for being a non-responder, a remitter to ECT is 3.8, nearly, pretty high. If you were subject to childhood physical abuse and neglect, it's 5.2. Again, very high, very clinically relevant. And for childhood sexual abuse, it's about 3. This is when it's adjusted. When we look at the association between maltreatment, the putative mediators, and ECT outcomes, the child maltreatment group were more likely to have persistent depression, again, odds ratio of 2.3, and more psychiatric comorbidity, odds ratio of 2.0. And both of these variables, for persistent depression and psychiatric comorbidity, had increased odds of being associated with non-remission overall. So this is the mediation analysis. So this is a DAG plot. So you have child maltreatment here. Our hypothesis this somehow contributes to ECT non-remission. And it's mediated by these two variables here. So psychiatric comorbidity, which we hypothesize feeds into chronic, these kind of long-term, long-standing, persisting depressive symptoms. And so this path analysis. So the direct effect from here to here is 0.1. The indirect effect, so just going through persistent depression here, that path there is 0.01. And then for any psychiatric comorbidity here, it's 0.06, which is pretty low. So the portion mediated by chronic depression here overall in ECT non-remission is due to child maltreatment is 7.4%. Now, what the rest of this is due, the other 90% is due to, we do not know with the data we have at this point in time. It could be genetic factors or some other aspect of the childhood environment that we do not tap into. So just to summarize that briefly, childhood maltreatment is associated with increased risk of non-remission with ECT for depression with an odds ratio of 3.5. As I said, the illness phenotype is pretty much as you would have expected with people with childhood maltreatment from what we know from depression in general. And non-remission was partly explained by these clinical features, psychiatric comorbidities and chronic depression especially, so persisting depressive symptoms. And it's interesting enough that Charles Kellner is quite a well-known ECT researcher, had a sort of medical hypothesis paper years ago where he cited, from his experience, clinical experience, that chronic depressive symptoms were poor indicators of response to treatment. And some of this seems to be due perhaps to childhood maltreatment. Now, limitations, it's a retrospective study. Sample size is really not large enough to specifically look at personality disorders. They're subsumed into comorbid psychiatric problems. And as I said, I think child maltreatment is probably underreported at admission to hospital. And there's probably some confounded by unknown factors, possibly genetic ones in early life, family experience as well. So, just to move on to something slightly different, and this is more preliminary data, I would say, than the first study. We were interested in looking at personality difficulties in ECT. So I'd mentioned that we already know that personality difficulties from this meta-analysis here contribute to poorer responses with ECT, actually increased sort of memory impairment and complaints of that. But one of the difficulties here is if you've ever done like a structured interview personality disorder, it takes about an hour. It's like the SCID personality disorder inventory, for example. So this does not get routinely done. So lengthy formal evaluation is rarely done. It's never done as a pre-ECT workup, or even in general psychiatric assessment. You know, I mean, in our center, we're increasingly using this tool, I would say, to make a formal diagnosis, because there's great value in that, I have to say. But if a brief screening tool for personality difficulties would certainly be useful if it was, had some prognostic value. And it was easy to use and acceptable. And one such screening tool is this one here, the Standardized Assessment of Personality, abbreviated scale, SAPAS. Has anybody here ever heard of this or used it? Good. You have? Yeah, great. Excellent. You can correct me then. This is developed by Paul Moran and Anthony Mann and colleagues at the Institute of Psychiatry, like a long time ago, 20 years ago plus. And it is at one level, it's the easiest thing to use, but it's also easy to do it wrong. And this is it. You just have 8 questions, and it's yes or no to each question, and you get a total score out of 8. And if you score more than 3, this highly suggests that person has a personality disorder. And I'll show you in a moment that there's good data to support that bold statement. But you have to ask if the person thinks that the description applies most of the time and in most situations. It's not like, oh, I'm very depressed, I feel terrible for the last 2 months, you know, I have no friends and so on. It's like for long standing. So do you have difficulties making and keeping friends? Would you normally describe yourself as a loner? Do you trust people, etc.? Very simple sort of questions, okay? And in their study, a cutoff of 3 on this 8-item scale had a sensitivity, very good sensitivity, specificity, positive and negative predictive values when compared to using a structured interview for DSM personality disorders. This is in a sample of patients attending psychiatry service, so not in the general population. And Moran and colleagues subsequently showed that the SAPAS predicts less favorable treatment outcomes in community treatment for depression with either psychotherapies or drug treatments in a big study of about 4,000 people. So we hypothesized that patients with depression and comorbid personality difficulties, I'm not saying personality disorder, personality difficulties, would have a diminished response to ECT. So this is different sort of methodology. This is a prospective study. And in fact, what we've done is pooled data from 3 separate studies, one of which is already published, where we actually use the SAPAS as part of the workup for people having ECT and these other studies. Again, in St. Patrick's, you had to be over 18. Depressive episode, for 2 of the studies we had SCID-4, or the other one was a clinical diagnosis of ICD-10, from ICD-10 for a depressive episode, unipolar or bipolar, and have a baseline Hamilton. So in this case, we have a Hamilton score now rather than the CGI, and need to score, I think it was over 18, and be cognitively intact. Basically exclude people who had any other major psychiatric illness apart from depression. If you had previously had ECT recently, or maintenance ECT, or involuntary to the hospital. So these are people who provided written informed consent to participate in the hospital, whereas the previous study was like everybody who had ECT. ECT was delivered the same way again. They had treatment as usual. Baseline measures were taken just a couple of days before having ECT, and therapeutic outcome was the Hamilton 17-item Hamilton, just within a few days of finishing the course of ECT. We this time used multivariable linear regression, fitted to the end of the intertreatment Hamilton scores. And the main predictor of interest was this presence or absence of personality difficulties as defined by the SAPAS. So a score of less than 3 is the kind of non-personality difficulty group, and 3 or more is the personality difficulties group. And then covariates were known predictors of ECT response, which I mentioned before, like baseline depression severity, age, presence of psychotic features, and so on. and we use data for this. So we had 114 people from the 3 studies, roughly half and half, not surprising. We see this in other depression groups. About 56, 58. So no personality difficulties, some personality difficulties. There's basically, apart from the personality difficulties group being slightly younger, 55 versus 61, there was no other differences between the groups. Okay, they got the same sort of treatments, same duration, acute duration of illness, I should say, and so on. So this just shows the 2 groups. So the higher the score on the Hamilton here, the more depressed you are, and it comes down with treatment. So pre-ECT, they're reg 20, 21, and they came down to here. So the adjusted mean difference in the Hamilton between the groups at the end of treatment was about 3.6 points, higher in the personality difficulties group here than there. Same information really here. This is an effect size of nearly 0.6, so again, clinically relevant effect size. And we look at response and remission rates. Again, this is the no personality difficulties, say for response, personality difficulties here. So reasonably large differences, especially for remission here. So the predicted probability of remission is about 41% in the personality disorder group and 70% in the group without. So in the logistic regression, the odds ratio associated with remission was 0.27. For response is a bit better, 0.31, but not much. So quite big differences there. So summarize this. So people with personality difficulties, and I'm not saying a personality disorder, we do not make a diagnosis. We're less likely to benefit from ECT. So this very easy to use instrument, SAPAS, I do not have shares in this. It's free as far as I'm aware. May be useful for predicting ECT outcome in depression. The findings are kind of concordant with previous studies reporting associations between personality disorder and dysfunction using other instruments. But here's something that's kind of pretty easy to incorporate into routine practice. In fact, everybody gets admitted to our hospital has this SAPAS checklist done as part of the admission. Now, it's a screening tool. It's not diagnostic. So you can't really infer association or lack thereof between formally diagnosed PD and ECT outcome. Has not yet been validated in ECT population against a formal diagnostic interview, although we're actually doing this at the moment, and to be honest, it looks like it's pretty good. The low prevalence patient with bipolar disorder, psychotic features may limit generalizability, obviously, of the sample, because the nature of the 3 studies, one of them didn't include people with bipolar disorder. So I would say in summary, we have 2 major aspects of the history, childhood trauma and personality difficulties that have these quite large clinical effects on response to ECT, and that we need to kind of incorporate into our thinking about treating people with ECT and trying to personalize the way you treat people with ECT, for example. And for that, I'd like to thank you here, the people involved in the studies. Anna was involved in both of these and took a lead in the data analysis. And I did notice today was National Sovereignty and Children's Day. So thanks for coming.
Thank you very much.